right. Good evening. My name is Robert Castro. I'm one of the USF Infectious Disease Fellows. The topic I'm going to be presenting today is orthopoxviruses and their related human diseases. The objectives for my talk are pretty straightforward. We're going to first kind of discuss what orthopoxviruses actually are, then spend the bulk of the conversation discussing variola virus, its impact, its eradication, and its clinical presentation. Then move on to monkeypox virus and its related human disease, and then briefly review cowpox virus and vaccinia virus and their related human diseases. So orthopox viruses are large, complex, double-stranded DNA viruses. They're brick or oval shaped, as noted on the right-hand side, with dimensions of 360 by 270 by 250 nanometers. Orthopox viruses, the genus, derives from the Orthopoxviridae subfamily and the Poxviridae family. And within the orthopox virus genus, there are four main viruses that have caused significant human disease in our history. First and foremost, variola virus, which is the causative agent of smallpox. Then monkeypox virus, cowpox virus, and vaccinia virus, including vaccinia-like viruses. In general, orthopox viruses are zoonotic infections, with the very glaring and unique exception being that of variola virus, in which humans are the only natural host. And orthopox virus infections are immunologically cross-reactive and cross-protective, which is significant when we discuss vaccination. So to begin with variola virus, or smallpox, variola virus is thought to have emerged as a human pathogen somewhere between 2000 and 10,000 BC, roughly around the time, in which humans developed the first major agricultural settlements, and when we started domesticating animals and started living in close quarters with animals. The earliest physical evidence is thought to be from the mummy of Ramses V, the Egyptian pharaoh, on the top left over there, that died in 1157 BC. So throughout history, smallpox has played a significant role, not just as a scourge of humans, but has shaped our history. Just to cite a few examples, it is thought that smallpox was the causative agent of the plague of Galen, or the Antonine Plague, which befell the Roman Empire between the years 165 and 180 AD, in which about 30% of the population died, and about 5 million deaths total. It also is thought to be responsible for the decimation of the Abyssinian forces when they attempted to conquer Mecca between the years 568 and 570 during the Elephant Wars. And also we know that smallpox facilitated the conquest of the Americas by the Europeans when it was introduced in the 16th century. And going forward ahead, in the 20th century, it's estimated that about 300 million people died from smallpox just within that century. And just to put it into perspective, that's about 3 times the amount of people that died in all wars combined during that century. So very significant. So ever since smallpox has been a significant pathogen for us, we've been trying to figure out ways to prevent it or avoid getting it. One of the earliest ways outside of quarantine and isolation that we use was a process called variolation. And so variolation was a process in which you would self-inoculate yourself with smallpox infectious material and hope that you get some kind of localized infection. But that procedure was not without its risk, and there was a 2% mortality with that. You know, at best case scenario, you had a localized infection, but sometimes you can get like a systemic infection, a smallpox-like illness. So fast forward ahead to the 1700s, the first major step towards eradication occurred when an English country doctor, Edward Jenner, knowing this or hearing the stories about how milkmaids who had contracted cowpox somehow were immune to smallpox, wanted to devise a series of experiments to test out that theory. So famously in 1796, he took infectious material from a milkmaid named Sarah Nelms, and he took it, and presumably she was infected with cowpox, and took that material, he called it vaccine, and inoculated a young boy named James Phipps in his arms. And months later, he came back and inoculated him with smallpox, and he didn't get sick. And so by doing that, he invented vaccination. So, so now going forward, just a little bit past the 1950s, smallpox was causing about 10 to 15 million cases in about 31 different countries worldwide. The areas of endemicity included sub-Saharan Africa, Asia from Bangladesh to Afghanistan, into the Indonesian archipelago, and Brazil. And around this time, even before 1967, the goal of eradicating smallpox was coming through as the newer technologies were coming up. And so in 1967, the World Health Organization intensified their efforts in their smallpox eradication program and performed a worldwide mass vaccination campaign. It was so successful that the last naturally occurring variola major case happened in 1975 on October 17th in a young girl on the left named Rahima Banu in the Bola Islands in the Bay of Bengal in Bangladesh. And then in 1977, on October 26th, the last naturally occurring variola minor case occurred in a young hospital cook named Ali Mao Malin in Merka, Somalia. And there were two subsequent lab-acquired cases in 1978 that occurred in the United Kingdom. And after just a few years of active surveillance, they didn't find any more case, and they were satisfied with their findings that there weren't any more case. In May 8th, 1980, the World Health Organization declared smallpox eradicated. So given its history and given how much of a scourge it's been on humankind, it's not hyperbole to say that it was one of the greatest achievements in human history. So to get into more detail with variola virus, again, it's the representative orthopox virus. Again, there is no non-human host for it, and also there's no subclinical carriers, which makes it a prime target for eradication. And transmission, importantly, is normally via a long time face-to-face contact, usually the respiratory route. And with variola virus, there's two clinical variants. There's variola major, which is what we picture when we think about smallpox, which had a fatality rate of about 30%. And within that, you can subdivide it, depending on the clinical form, into at least five different presentations. And then there's variola minor, which was a less severe form with a fatality rate of about 1%. And we'll get into more detail about the variola major, different kinds. So now I'm just going to talk about the clinical course of variola major, which is what we think about when we think about smallpox. So first, a person that would get infected, usually the respiratory route. Once they acquire the virus, there's thought to be a subclinical primary viremia that occurs. The macrophages pick up the viruses, they settle into the reticuloendothelial system, and the virus starts to replicate. This incubation period usually lasts between 7 to 17 days, median being about 10 to 12 days. And then as there's significant amount of replication, there's a massive secondary viremia. And that's when you start going into the prodrome phase, which is when you start having symptoms. So you start having symptoms like fevers, headaches, backaches, myalgias. And that lasts about 2 to 4 days. About the end of that period of time, about day 3 or 4, you start getting the first lesions of smallpox, which usually occur in the mouth, the oropharynx, and the tongue. And after those appear, the following day is when you get the classic smallpox rash that begins in your face and your head and then goes downwards, particularly in your extremities and your head and your face. And it's this period of time when the first rash appears that you're the most infectious, because there's such a high concentration of the virus in your respiratory secretions that you can easily pass it along to somebody else. And so once the rash appears, it goes its natural evolution from macules to papules to vesicles, then pustules, and eventually after 7 days, the scabs start to come up, and at that point in time, you're still technically infectious because the scabs do have infectious material, but the rate of transmission is much less compared to the early days of the rash when you have such a high concentration in your respiratory route and your respiratory system. And so all the lesions eventually scab over, and eventually they slough off, and at that point you're no longer infectious, and you're typically left with the sequelae of pockmarks. So this is ordinary smallpox. There's three clinical uh, presentations of it. The top left is ordinary discrete, which is what we typically think about smallpox. The lesions, again, are predominant in the head and the face and the extremities, especially the upper extremities. The lesions tend to be painful, and they tend to have normal skin in between each one of them. Then there's ordinary semi-confluent smallpox, which is the one on the right, where there's a somewhat of a confluence of the lesions on the head, and you still get kind of a more dispersed presentation on the extremities. In the bottom left is ordinary confluent smallpox, which you not only have confluence of the lesions on your head and your face, but also it's confluent on your arms and your legs. As you can see, there's a lot less normal skin in between each of the lesions. Then the more deadly or the deadliest forms of variola major are flat and hemorrhagic smallpox. These had a mortality rate over 90%. Flat smallpox is the one on the left. These patients tend to have a clinical course similar to people that had Stevens-Johnson's or severe burns, and they had massive tissue loss. Because of it, the lesions, as the name implies, were flat and more confluent with each other, and eventually death occurred in over 90% on people because of tissue destruction. Hemorrhagic smallpox was a fulminant version of smallpox, in which people presented, at least they said it presented like almost meningococcemia. It was a very fulminant disease, and people typically died within the first 7 days. You know, bleeding, coagulopathies, hypotension, shock. A lot of times, just because it was so aggressive and so quick to kill you, the typical normal smallpox lesions didn't even have time to show up, so sometimes you wouldn't even know it was smallpox before the person already died. So complications associated with smallpox, of course, are death, also bacterial superinfections of the skin. Also, it's been documented like corneal ulcers, keratitis, pneumonia, encephalitis. Also, obviously, the sequelae that we normally associate with smallpox are the pockmarks, specifically in the face. So, even though smallpox is now eradicated, it's still something that we should know about because of the concern about its reemergence, specifically as if it was used as a bioagent in the case of bioterrorism. So the CDC has come up with a clinical assessment tool, a clinical algorithm you can use to assess patients at an acute febrile illness with a diffuse vesicular pustular rash. And just like all these different clinical algorithms, usually there's some kind of combination of major and minor criteria, and then you risk stratify them into low, moderate, and high risk. And I put the picture of the smallpox rash, comparing it to the chickenpox rash, because the chickenpox was importantly was the one disease that usually got confused for smallpox, and it plays a big role in the algorithm. They had to rule out chickenpox. So the major criteria are three of them. Include, first one is a prodrome. So the presence of a prodrome of 1 to 4 days before the rash begins is very important, because that also is something you can help differentiate different diseases, because some diseases you get sick before the rash comes on, and other diseases you get sick when the rash comes on. So that's very important to have. Then number two is having the classic smallpox lesions, these kind of firm, round, usually tender, deep-seated pustules. And then, as we've always learned, all the lesions have to be in the same stage, particularly if they're on the same side of the body or same part of the body. Minor criteria include that the rash has to be in a centrifugal distribution, meaning it's more predominant in the extremities than the torso. The first lesions have to be in the oral mucosa or the face or the forearms. Patient has to look sick. And there has to be a slow evolution between the stages of the rash. It can't just be a rapid progression. Then if there's lesions in the palms and the soles, that's also considered a minor criteria. So you take your patient, you figure out what criteria they meet, and you kind of plug them into what risk category they are. If they're high risk, that means that they meet all of the three different major criteria. If they're moderate risk, there's two different clinical scenarios. One is that they have a febrile prodrome, and at least meet one other major clinical criteria, or they at least meet four of the minor smallpox criteria. And then low risk patients are one that have no or mild febrile prodrome, or they do have a febrile prodrome, but they have less than 4 associated minor criteria. And so here's the algorithm. So first you have your patient in the top that has a fever and a diffuse rash. First thing you do is you put them in airborne isolation, contact infection control. You risk stratify them, low risk, moderate risk, or high risk. The left side is the low risk. Basically, you don't even have to worry about smallpox at that point. If your patient falls into that category, they recommend considering ruling out varicella. And if that comes back negative, you should think about the other things in your differential, not necessarily smallpox. For moderate risk patients, these are patients you take a little bit more seriously. You get either infectious disease or dermatology involved, and the first thing you do is you rule out varicella, or any other first varicella, and then after varicella you rule out all the other stuff that might be in your differential. Once that comes back negative and you still have a high suspicion of smallpox, at that point is when they recommend that you send out for testing. For high risk patients, those patients you automatically just call the authorities and send out your sample. You don't play around with those. All right. So speaking about vesiculopustular rashes, the other things you can think about in the differential as far as ID include other herpes viruses, again, varicella, shingles, disseminated herpes, eczema herpeticum, also, of course, orthopoxviruses, including smallpox, but also like monkeypox, COWPOX, particularly in immunocompromised, also VACCINIA-like viruses in the immunocompromised patients. Molluscum contagiosum as well, specifically in immunocompromised patients. Disseminated gonococcus, because it could have present with disseminated pustular lesions. Secondary syphilis, because it can look like anything. Hand-foot-mouth disease by Coxsackie, and enterovirus as well. Non-infectious causes of diffuse vesiculopustular rash can include a drug reaction, also Sweet syndrome, and of course Stevens-Johnson's. So here's just a couple pictures. The top left is chickenpox, varicella. The lesions classically are in different stages. The bottom left is shingles, vesicular lesions. Both pictures on the right, the top and the bottom, are patients with eczema herpeticum, which is herpes simplex in the setting of a patient with atopic dermatitis or eczema. It can have a very exaggerated response or illness. The left is disseminated herpes simplex as pustules. On the right, on top right, that's disseminated gonococcus, pustular lesions, disseminated. And in the bottom is disseminated molluscum in a patient that's immunocompromised with DOC8 deficiency. And of course, this is syphilis, lesions on the palms and soles, the torso, typically papillosquamous, but also can be pustular as well. Non-infectious, on the left, we have a drug reaction, a vesicular drug reaction. On the right, Sweet syndrome, and the top is a patient with recurrent sweets in the setting of leukemia, and the bottom right is Sweet syndrome in the setting of an IV drug user. So treatment for smallpox, usually supportive. They also recommend monitoring for obviously bacterial superinfections. The vaccinating someone for smallpox does have a role in post-exposure prophylaxis. Specifically if it's given early on. They say anywhere between 3 and 7 days, obviously the earlier the better, that if you vaccinate someone that got exposed to someone that had smallpox and you vaccinate them, there's a chance you might prevent the infection from coming on, or at least decrease the severity of the infection. But after those patients develop a rash, at that point it's no use to vaccinate them. And the role of antivirals is unclear. There's no official recommendation to use them, more particularly because there's never been a patient that's these antivirals weren't real commonly used at the time, so there's never been tested on actual people with smallpox. But they have been shown in studies to be effective against orthopoxviruses. So the CDC keeps a stockpile of tecovirimat and cidofovir in hand in case there's an emergency outbreak, because theoretically they should be somewhat effective. So smallpox vaccination, the classic smallpox vaccination was Dryvax, but now in the US we have ICAM 2000, which is the one officially licensed in the US. It's a live vaccine. As we know, with live vaccines, there's a lot of different contraindications that come along with live vaccines. Um, we administer it by giving one dose in people usually over the age of 18. Right now, there's kind of a question about whether people need to be revaccinated. It's been shown that people do have a waning immunity over time, but there's no official recommendation that they need to get any more than one dose. And other important dates when it comes to the history of vaccination, of course, 1796 with Edward Jenner. The 1940s, when the development of the freeze-dry technology came on, actually allowed the vaccine to be taken and for longer periods of time in tropical areas. And then in 1965, the the development of the bifurcated needle made the smallpox vaccination much more efficient and was crucial to the smallpox eradication program. And then in 1983, the vaccine was officially removed from the civilian market after smallpox was declared eradicated in 1980. So here is what normally the vaccine site's supposed to look like. It's supposed to progress like most pox lesions. You have a vesicle, pustule, then eventually it scabs over and the scab falls off. Contraindications to the vaccine, again, it's a live vaccine, so as you would expect, it's contraindicated in immunosuppressed people, pregnancy, breastfeeding, people with significant dermatological conditions like eczema, exfoliative conditions, kids under the age of 1, and people that obviously are in some kind of acute illness. So this, what's it called? The vaccines aren't without, its possible adverse effects. And some of the documented adverse effects include here in the top left, inadvertent auto-inoculation is basically when you touch the site where you got vaccinated and kind of touch somewhere else on yourself. In this case, it was a kid that touched his face and auto-inoculated himself with vaccinia. And in the bottom left is generalized vaccinia. It's patients that they get the vaccine and sometimes they can get multiple lesions just distal to the lesion. It could be few and it could be pretty significant. It can be generalized. The center picture is eczema vaccinatum, which occurs in patients that have some kind of underlying dermatological condition like eczema or atopic dermatitis. On the right is progressive vaccinia or vaccinia necrosum, which occurs in people that are immunocompromised. So the vaccine site progresses into this large ulcerated necrotic lesion. And death has been attributed to the vaccine, and also post-vaccinal encephalitis has also been a documented adverse effect. And so the issue, since its eradication and since we're no longer routine vaccinating people, there's a concern about waning immunity in the world and in the community. And given that smallpox can be aerosolized and has a significant amount of mortality in people that are unvaccinated of 30%, there is a significant concern that it can be used as a bioagent in bioterrorism. So it's categorized as a category A bioagent, which is the highest category you can put. Does anyone else know what the other category A bioagents are? Smallpox. Plague. Yeah, and viral hemorrhagic viruses. Good. All right. Any questions on smallpox? Not right now. All right. So, anyone know what this is? I'll give you a hint. It was associated with an outbreak when they came in contact with African giant pouch rats. That's pictured right there on the left. That were imported from West Africa. So those are prairie dogs. And the outbreak was monkeypox. So monkeypox virus was first discovered in 1958 in captive primates in Denmark, thus the term monkeypox. But the natural reservoir is suspected to be rodents, including squirrels, Gambian pouch rats, and mice. It was recognized as a human infection in 1970 during the smallpox eradication program, when it occurred in I believe it was a 9-year-old girl who lived in a village who had not seen smallpox in about 8 months. So that's why they looked into a little bit further. And it happened in Zaire at the time, which is now the Democratic Republic of Congo. Currently, monkeypox is endemic in the DRC and other kind of sporadically in the neighboring countries within the Congo Basin. It is important to know that there's two virus clades. There's the West African clade, which is the one that came over to the US, and the Congo Basin clade, which is considered to be more pathogenic and cause more severe disease. And typically it's transmitted via direct contact with infected fluids or mucosal lesions. Here's a picture of a prairie dog with the lesions on the nose, blepharitis. So that's the outbreak that happened in 2003. Is a multi-state outbreak, 6 states beginning in Wisconsin, at least 47 cases. These patients came in contact with prairie dogs that were sold as pets, and those prairie dogs came in contact with infected African giant pouch rats, dormice, and rope squirrels that came over from West Africa. And it's important to know that it was just the West African clade that caused this outbreak, because the clinical presentation was a lot less severe than what we normally see in the DRC. So the clinical features of monkeypox, obviously there's an incubation period, usually between 6 and 16 days. Then there's an invasion period that usually lasts up to 5 days, which is kind of like a prodrome, where you have fevers, headaches, lymphadenopathy, particularly back pain, low energy, and myalgia. And then about a day or 3 after the fever starts, then you get the skin eruption phase, and you get what is a rash similar to smallpox, in that it starts in the head and the face and kind of spreads down, particularly involving the extremities and the head and the face. Severe lymphadenopathy is a distinctive feature of monkeypox, and when you compare it to smallpox, so that's something you can help differentiate the both of them. So on the left is a patient from the Congo with monkeypox, lesions predominantly in the face and the extremities, also in the palms. And then on the right is another patient with monkeypox with significant occipital lymphadenopathy. So treatment, there's no specific treatment and no specific vaccine for monkeypox, but vaccination, again, because orthopoxviruses are cross-protective immunologically, vaccination against smallpox has been proven to be at least 85% as effective in preventing monkeypox. So moving on from monkeypox to cowpox. Cowpox is so named because it can infect the udders of cows. Classically, cowpox is the virus that Edward Jenner used for his vaccine, and it's not really clear when the transition happened, that they went from cowpox to vaccinia virus, but supposedly it happened sometime in the 19th century. No one knows when, no one knows how, but apparently it happened, and now we can't go back. Cowpox is endemic in Europe and the Caucasus and Eurasia area. The reservoir is small rodents, including bank voles there in the top right, and wood mice. And the primary zoonotic source nowadays is the domestic cat. So you'll see a lot of case reports with people that get in contact with cats and then develop these lesions of cowpox. But also it's been documented that you can get it obviously from cattle, but also from elephants and rhinoceros. And transmission usually is with contact with the skin lesion. So the clinical features, typically it's a localized pustular lesion or ulceration with central hemorrhagic necrosis. These are all case reports of it. Again, localized, some local edema, erythema. Disseminated disease is possible, particularly in people with immunocompromised conditions or exfoliative skin conditions. Okay, and finally, vaccinia virus and vaccinia-like viruses. Vaccinia virus itself is the virus that we now use for smallpox vaccination. Its origin and natural host is not really known. At this point, vaccinia virus is only found within our vaccine supply, and it's not naturally out there in the world. So any kind of disease related to vaccinia virus proper is related to people that are social contacts to someone that had smallpox vaccination, and they somehow get in contact with the lesion, and then they get the lesion and they have vaccinia. But there are wild vaccinia-like viruses out there that are known to cause zoonotic infections, particularly in cattle and buffalo herders in India, and really well known in dairy workers in southern Brazil, where the disease is called bovine vaccinia, and it's a well-known occupational zoonotic infection. So clinical presentation is kind of similar to that of cowpox. It's a localized lesion with associated edema. It will become eventually a necrotic and painful ulcer by about 2 weeks, and usually associated with some semblance of systemic symptoms. So here are some pictures of bovine vaccinia in dairy workers in Brazil. So, in conclusion, variola virus, smallpox, has played a major role in human history, with eradication being one of the greatest public health achievements in history. Though less commonly seen, the non-variola orthopoxviruses still play a role in zoonotically transmitted human disease, and are important to know because they have the capacity to cause severe illness in immunocompromised patients. So, just one last thing, that if you do want to go into a little more in depth about the smallpox eradication, I would recommend this book, written by D.A. Henderson, which was the chief of the smallpox eradication unit for the WHO. Picked it up in college. I've read it a couple times, and it's great. So if you guys want to, highly recommend it. All right, that's it. That's references.